Good morning, everybody. Today's presentation is going to be given by Dr. Karen Mostert. She is a chemical pathologist with 27 years of experience in pathology. She obtained the MBChB degree at University of Pretoria in 1990 and qualified as a specialist in chemical pathology through the College of Medicine in South Africa in 1998. She has been working in private practice since 2000, working with Vermaak and Partners, and has been part of PathCare since 2016. Her professional interests include laboratory quality management, point-of-care testing, and the use of laboratory data to support value-based healthcare. Her clinical interests focus on markers of myocardial injury, endocrinology, and pathology relevant to emergency medicine. Today, Dr. Karen is going to talk about the toxic truth, killing pests and endangering lives. Thank you, Karen.
Thank you very much, Michelle. So as you can gather from the topic, so we are talking about insecticides today, and the three most common ones we do encounter are the organophosphates, carbamates, and pyrethrins. So I will be looking at the background and epidemiology, mechanism of action, kinetics, clinical presentation, specific syndromes, all the different names going around, principles of the management, the utility of the enzyme levels, and how we can track recovery of these patients. Just a quick case study. It's something the emergency room encounters quite often. Here we have a 20-year-old male patient presenting comatose with seizures, diarrhea, hypersalivation, history of recent intentional exposure to pesticides on chemical examination, a Glasgow coma score of 7, not a bradycardia, pulse of 118 per minute, blood pressure 110/70, low saturation, respiratory rate of 25 per minute, meiosis, bronchorrhea, and bronchi. So keeping that in mind, looking at the background and the epidemiology, the organophosphates were initially studied as insecticides in the 1930s. They then realized it has a very high toxicity, and this led to the development of nerve agents during World War II. After the World War, organophosphates were used as pesticides since 1950, and in the meantime, there was declined use owing to the introduction of carbamates and pyrethroids, especially since 2000, which has an improved human safety profile. So very toxic to the insects, not so toxic to humans. But obviously, we know all three of these agents are still around. So pesticide intoxication is a major global health issue, especially in agricultural regions with high pesticide use. We see higher poisoning rates in the low and middle income countries owing to less pesticide regulation and high exposure risk. And worldwide, there's approximately 3 million people exposed to organophosphates and carbamates annually, with up to 300,000 fatalities. And in South Africa, although it is a notifiable disease, the exact incidence is not really known, and the case fatality is estimated to be as high as 30%. As we say, the exposure can be either accidental or intentional exposure via the skin, inhalation, or ingestion. Some points about the mechanism of action. We will discuss it in detail a bit later. Organophosphate poisoning occurs when the enzyme acetylcholine esterase is irreversibly inhibited by phosphorylation. There's a conformational change happening called aging. It's compound specific, exactly how the timing works, and it is resistant to reactivation by antidotal oxime, so your prolidoxine. Carbamates, on the other hand, are transient acetylcholine esterase inhibitors. It reversibly inhibits the enzyme by carbamylation, and then you get spontaneous hydrolyzation from the enzyme site within 48 hours, where the enzyme is then again active. So this inhibition of both the organophosphates and the carbamates causes a rapid accumulation of the acetylcholine at the nerve endings, and this leads to severe overstimulation of your cholinergic and central nervous system receptors. On the other hand, pyrethroids has nothing to do with this enzyme. It causes prolonged activation and opening of the voltage-gated sodium channels, prolonged depolarization, which then causes sustained neuronal firing and neuroexcitation, and you actually get two types of pyrethroids. So just looking at this picture, it basically depicts what we said now. In the picture to the left, it is the normal acetylcholine transmission and degradation of acetylcholine via the enzyme. So you have lots of acetylcholine released, but not all of that will cause a neuronal signal. While the picture on the right then depicts your poisoning with organophosphate and carbamate, where you get accumulation of acetylcholine in the synaptic junction with continuous firing of the postsynaptic neurons or myocytes. Just some detail about the chemistry of aging. It's a lot of figures and compounds that you're looking at, but in short, if we look at the pictures, the first picture then shows the organophosphate molecule being attracted to the enzyme. We see that the acetylcholine esterase has two binding sites, an anionic site and an esteric site. Usually the acetylcholine would bind to the anionic site. In this case, the organophosphate is attracted to the serine, and in the transition state, there is a bond forming between the phosphorus atom and the oxygen on the serine group, and there is a breakdown of the phosphorus group to the functional group bond happening. So this is called the transition state. Once we move on to the aged bond, you will see that there's a covalent bond that formed between the phosphorus and the oxygen that cannot be broken. So that at this stage, pralidoxime will not work. So pralidoxime will only have an effect once it's in that transition state. Once it reaches the aged bond, no effect at all. So as we have said, it's very much compound specific. So we very seldom know exactly what type of organophosphate the patient actually was exposed to. So we don't know how long this aging process might be taking. So it is dependent on the chemical structure of the organophosphate. Previously, it was thought that pralidoxime should be given very early, but later studies show that it can still be effective even after 48 hours, so 2 days. And then on the other hand, carbamate, it follows much the same process with a carbamol molecule binding to the serine state, but it does not age. So pralidoxime in those cases always effective if you catch it early. So looking at the kinetics of organophosphate and carbamate poisoning, the onset and the duration of this enzyme inhibition varies. It depends on the dose, it depends on the route of absorption, the lipophilicity, and if the original compound is converted to active metabolites. So for most organophosphate and carbamates, the oral intake or the inhalation has a clinical effect within 3 hours, but if there was dermal exposure, it can be delayed up to 12 hours. Some of the lipophilic agents, and notably their malathion, which is quite a common organophosphate, has a delayed onset, with coma and respiratory failure occurring up to 5 days later in patients with initial mild cholinergic symptoms. And then we can even see prolonged illness after 30 days, which may be related to rapid adipose uptake, but then a delayed redistribution from the fat stools, as well as the conversion of the original compound to active toxic ingredients, for example, parathion. Looking at the symptoms of acute organophosphate and carbamate poisoning, we know that the cholinergic effects will be the muscarinic and nicotinic effects, and then there's also the central nervous system effects. Muscarinic effects, there are all sorts of acronyms that you can use, but it includes salivation, lacrimation, urination, diarrhea, cramps, vomiting, meiosis, bronchorrhea, and bradycardia. The nicotine effects will include muscle fasciculation and paralysis, tachycardia, and hypertension. So you can see there's a bit of a discord between the pulse rate here. There can be bradycardia, maybe a tachycardia. So most patients will present with features of parasympathetic overstimulation, which includes bradycardia. But some patients may present with signs of sympathetic overstimulation, which will present with tachycardia. And the tachycardia may also be caused by hypovolemia and hypoxia, which you see in these patients. So the most frequent cause of death is respiratory failure due to bronchoconstriction, bronchuria, central respiratory depression, diaphoresis, and weakness or paralysis of the respiratory muscles. Just a note on the atropine challenge test. Often with the initial presentation, the patients have vague or conflicting symptoms, and the signs or the source of intoxication is unknown. You can give a bolus of atropine, and if the heart rate increases more than 20% or more than 30 beats per minute over the baseline, it is considered positive. And in the case of a positive test, organophosphate and carbamate exposure is likely. Two specific organophosphate syndromes. The first one is the intermediate or the neurologic syndrome. Can occur in up to 40% of patients with organophosphate poisoning, usually 1 to 4 days after exposure and after the resolution of the initial cholinergic excess. It's often seen in patients who were exposed to highly fat-soluble organophosphates like malathion, or where they were treated with inadequate doses of pyridoxine. It's rarely described after carbamate poisoning, and this then usually resolves after 2 to 3 weeks with adequate supportive care. If you were in a position to do an enzyme level, then the clinical deterioration and improvement would correlate with your red blood cells, acetylcholinesterase activity. The second organophosphate-specific syndrome is the organophosphate-induced delayed neuropathy. And in these patients, it will occur 1 to 3 weeks after organophosphate exposure. It's a transient, painful, and a stocking glove type of paresthesia, followed by symmetrical motor polyneuropathy. It's a flaccid weakness of the lower extremities, ascending to the upper extremities. And the most mild cases can improve with time, but severe cases can cause permanent disabilities with upper motor neuron syndrome with spasticity of your lower extremities. So the risk of developing this OPID syndrome is independent of the severity of the acute cholinergic toxicity, and is also associated with very specific organophosphates like chlorpyrifos, and it is rarely seen in case of carbamates. So just interesting to note, not to say that if they survive the initial acute crisis that they are out of the woods. Looking at the mechanism of pyrethroids, we said it has nothing to do with the acetylcholinesterase enzyme. The picture depicts the extracellular area versus the intracellular phase with your voltage-gated sodium channels. So in this case, in a normal patient, you would have limited sodium entering the intracellular space with membrane depolarization, sodium current, and action potential developing with muscle contraction. In the case of pyrethroids, and remember there are two types, you get prolonged activation and opening of these voltage-gated sodium channels with sustained neuronal firing and neuroexcitation of the cholinergic receptors. The next slide then talks about the kinetics and the symptoms. So just to remember, pyrethroids, it's a man-made chemical. It's based on the chemical structure of the chrysanthemum flower. So in these patients, these symptoms present rapidly, typically 30 minutes to 2 hours, so quite shorter than the organophosphates and the carbamates. Patients who had a mild inhalation exposure will present with respiratory tract irritation with a cough, mild dyspnea, sneezing, rhinorrhea. Mild ingestion exposure is associated with nausea, vomiting, and abdominal pain, while patients with marked exposure will have systemic toxicity, headaches, dizziness, anorexia, hypersalivation. Severe poisoning is uncommon. It will usually follow substantial ingestion. Patients present with impaired consciousness, muscle fasciculations, convulsions, and really non-cardiogenic pulmonary edema. So just looking at that, you can see that there might be some confusion if you do not know the exact compound which the patient was exposed to between even the pyrethroids and the organophosphates and the carbamates. So the type 1 pyrethroids are typically associated with the T syndrome, where the patients have ataxia and whole body tremors, while the type 2 pyrethroids are associated with chronic seizures and hypersalivation, also known as the CS syndrome. So in these patients, the symptoms typically resolve within 24 hours to 6 days with supportive care. The management of these patients, it's the usual decontamination, supportive care, and then specifically atropine and pralidoxime. So the atropine competes with the acetylcholine at the muscarinic receptors, preventing cholinergic activation, but it does not treat neuromuscular dysfunction because it does not bind to the nicotinic receptors. Pralidoxime has a variable response. Once again, the timing of aging is important and it is compound specific. Pralidoxime may improve mortality and intubation rates according to the literature. So as we said, the timing of aging depends on the specific compound, and studies indicate that pralidoxime can be effective long after 40 hours, as we have seen. Pralidoxime may also decrease the development of the intermediate syndrome or the organophosphate-induced delayed neuropathy. Epinephrine may also be used as a second line, not responding to atropine. For the management of pyrethroid poisoning, same thing, decontamination, supportive care, and as you can imagine, atropine and the oximes have no role in a pure pyrethroid poisoning, should you know what the compound was. So it is used in cases of diagnostic uncertainty or where you suspect co-exposure with organophosphates and carbamates. So what is the role of the routine lab in pesticide poisoning? So the lab can basically do 2 enzyme activity measurements. The one is serum choline esterase measurements. They are readily available, usually done at the central lab. So it's not a rapid turnaround time. If your hospital is close to the centralized lab, it can happen quickly. Otherwise, it can be 2 or 3 hours or even more before you get a result. Acetylcholine esterase is the other enzyme that can be measured. So it's usually the whole blood or the total acetylcholine esterase that is done. It is available with an even longer turnaround time. It's a batch test. It can take 2 or 3 days. Just to give you an idea, you should not be waiting for a result before you manage your patient. So the diagnosis is a clinical diagnosis. So the enzyme levels that we do, serum choline esterase, can be used to confirm the diagnosis of organophosphate or carbamate poisoning, and it correlates well with cholinergic signs. And remember, it will be normal in pyrethroid poisoning. The red blood cell or the total choline esterase is used for agricultural monitoring of organophosphate and carbamate exposure according to the legal requirements. And then one would wonder, is it possible to actually measure? Am I now sitting with malathion or parathion? And in theory, it is possible, but it is expensive. It's not routinely done, and it will have a long turnaround time. So what's in a name? There are many names going around in the literature, how the labs report it. So we say we do the 2 types of enzymes. Looking at the acetylcholine esterase, it's also known as true choline esterase or the red blood cell choline esterase. So this is basically the enzyme that you get in CNS, the neuromuscular junctions, the autonomic nervous system, red blood cell membranes, the lung and the spleen, and here it hydrolyzes the acetylcholine to acetic acid and choline. So very much a functional scenario. The half-life of acetylcholine esterase is very long. It relates to red blood cells, half-life of about 120 days. On the other hand, the serocholine esterase, also known as butyryl choline esterase, plasma choline esterase, serum choline esterase, these enzymes are synthesized in the liver. You'll find it in plasma and serum, also in kidneys, the intestines, pancreas, and the low concentration in the central nervous system. And this is more related to pharmacology. So it will hydrolyze your choline and non-choline esters like succinylcholine and myocardial. So typically the choline apnea workup that the anaesthetists will be looking at if they find low levels of pseudocholine esterase. So the utility, looking at serum choline esterase, it is available. We said mostly at the central laboratories. It's a sensitive but a less specific marker. We look at other scenarios where you can also get low values. It reflects hepatic enzyme synthesis and systemic exposure. And this is what we routinely use for acute intoxication. If we look at the red blood cell choline esterase, this method in the laboratory per se is not available anymore. The reagent kit is not available worldwide. So the labs have improvised, and we now report a total or a whole blood choline esterase. But it has very much the same function in your workup as the red blood cell choline esterase. So it reflects the synaptic acetylcholine esterase activity, and it correlates more closely with neuromuscular and respiratory function. So we definitely use this total or whole blood acetylcholine esterase in the agricultural exposure setup. So serum choline esterase does correlate with cholinergic signs. So if the enzyme is inhibited by 20 to 50%, these patients will present with headache and fatigue. Moderate poisoning, where the enzyme is inhibited by 80 to 90%, they will have weakness, muscle fasciculations. And in cases of severe poisoning, when the enzyme is inhibited by more than 90%, they will present with coma, passive paralysis, cyanosis, and the more severe signs. Just looking at the normal reference ranges for serum choline esterase, I noted the reference ranges that we have on our platform for the beta-aryl choline esterase method, and you will see that there are different ranges for males versus females. And you will also note that it's quite a wide reference range, from about 4,000 up to almost 11,000 in males. So very important to get the person's own baseline to see where you are working from there. And then the same for the whole blood choline esterase, also quite a wide reference range there. So if you do start in the emergency room with one method's choline esterase measurement, you should continue with that when you do serial follow-up. It's not standardized between labs. So the serum choline esterase measurements, as we've said, you will be looking at that for organophosphate or carbamate poisoning, not necessarily the diagnosis, but definitely the monitoring. And then, as we say, for the patients presenting with choline apnea, you will be doing it for inherited beta-aryl choline esterase deficiency. And if it is very low in that scenario, there are further tests that you will be doing, like the diplocaine inhibition for phenotyping as well as genotyping. We said that the serum choline esterase low values are not specific only for organophosphate and carbamate. Other settings where you can also get low values, obviously the inherited variants, as we have said now. So there are quite a few going around, but the AA, AS, and SS variants will present with a severe risk with quite low choline esterase levels. Liver function, malnutrition, pregnancy, and drugs can all be implicated in low levels as well. So if you think, they will rarely present with levels of 200 and 300, but they will be below the lower limit of the reference range. But organophosphate and carbamate poisoning and the severe risk inherited variants will all present with very low values. So how do we track recovery? Looking at the serum choline esterase, it recovers fairly rapidly, days to weeks. It depends on your hepatic synthesis of the new enzyme and the cessation of exposure. So if you have a patient with liver pathology, with synthesis impairment and organophosphate poisoning, you will not recover as quickly as other patients might do. An early rise in the enzyme will suggest effective decontamination with no ongoing absorption, and it is useful for the early monitoring of recovery. The red blood cell choline esterase, or the total or whole blood choline esterase, recovers more slowly. weeks to months. It depends on the red blood cell turnover, as well as new enzyme synthesis. So persistent depression will reflect severe poisoning, enzyme aging, or a risk of prolonged neuromuscular weakness. It is a better marker for monitoring functional recovery. If you would be able to do it rapidly with a quick turnaround time, it can help your management for weaning from ventilation support. And then, as we said, also to predict the risk of intermediate syndrome. As we've also already noted, it is the best marker for chronic exposure monitoring in the agricultural setting. So going back to our patient in the case study, this is what his blood tests look like. So you can see that he presented with a very low serum cholinesterase. So if you look at that lower limit of 4,300, it is more than 90% suppressed in this case. Following, it was about 3 days later, it was performed again, and we see that the serum cholinesterase actually dropped. So this does probably reflect that there was inadequate decontamination and ongoing absorption of the toxic agent. So in this patient's case, after about 5 days, the organophosphate did start to pick up. And in this patient's case, it was established that it was actual organophosphate exposure. So this is a typical picture that we see. Just to give you some idea of the products, we think organophosphates, it will never hit us, but it's actually present in products that we use in the home. So you will see that the in-house type of pesticides, there is a move away from organophosphates. So most commonly you will see that it's pyrethroids, which has a higher human safety profile. Often it can be combined with pyrethroids and carbamates. So Doom and even Blue Death. The first slide that I showed was the leopard moth attacking the cycads, and Blue Death is a very typical remedy for that. So it is around. Even a toxic organophosphate like malafide is available for home use. You can buy it off the shelf. Looking at other products, the top one, Aldecarb or two-step or Temic, Galiperini, all the synonyms there, was banned in 2016. And the very toxic organophosphate used for agricultural use, Turbifos, was banned in June. So you will remember from the news clips that these are cases where many people died following exposure. So the Temic or Aldecarb was banned after 6 children ingested organophosphates, which they got at the disposal shop, and it was banned. Turbifos, the same thing. It's almost many people dying, which causes the banning of these. And if you look at the state of toxic agents in South Africa, it is said that there are about 194 very toxic compounds, and they actually need to go through all of those to see what can they eliminate. Because in the agricultural sector, there may be some better monitoring, but these agents find their way to the people. And it is really devastating. It can be. That's a high mortality. So just some key points. The organophosphates, carbamates, and pyrethroid insecticides are most commonly implicated in acute intoxication. The specific compound implicated is often unknown, and management should be guided by clinical findings. Prolidoxime is effective before aging occurs, and the timing is compound specific. Serum cholinesterase is available to monitor acute intoxication of organophosphate and carbamate compounds. Low serum cholinesterase activity is not specific for organophosphate or carbamate poisoning. The whole blood or the total acetylcholinesterase is available for monitoring chronic exposure. The pyrethroid toxic effect is via the sodium voltage-gated channels, and your enzyme levels are not effective, thus not useful. Delayed syndromes may be associated with organophosphate poisoning. So to conclude, I think we can all realize that insecticide poisoning is not an exact science. There are many unknowns, many variables, should be guided by clinical findings. But I do hope that my presentation gave you some insight into how the pathophysiology links with a clinical presentation and how the lab might help you with your management. Thank you.
Thank you, Karen. Karen actually been very humble. I think she's actually the COO of PathCare for a number of years. And that was really, I think, probably she contributed massive success of PathCare in Northern region. Thank you for that. That's why I get to know PathCare. But going back, I really want to say thank you for taking us back to California in Steve Biko. And those who even work in Tembisa, Karankua, this is really more of mostly underprivileged suicide method, actually. You will see quite a massive of them. And there's something that you mentioned very special that we always see this patient in California, that you actually treat them, you see coronary risk goes up nicely, you're happy, you send them to the ward, they fall and die. We see that quite frequently. The question that, why? Okay, is it the regeneration of the organ phosphate? Because I think it's different between carbamet and organ phosphate in terms of how do they block the acetylcholine receptors. Okay, and yeah. So the second thing that for fellows, we see this in the ICU exams questions. We get them there when we did our ICU, that was the question we get in the ICU exams. So it's quite common in South Africa. Yes, we don't see a lot of it in midstream, but because of the people here got a different way of committing suicide, okay, as compared to underprivileged. So yeah. But thank you. This is really quite good presentation.
Thank you for your nice presentation. So I need to know, in the guidelines now, there's nothing mentioned on heme absorption. Because I know there's a lot of, in terms of management and treatment on heme absorption.
I've not focused too much on the management. I've basically given the big principles and how the redoxy might impact the chemistry, but usually
There's big studies happening in the vet sector in terms of heme absorption. One of the, especially in patients that land up in it.
Is it decreased absorption or increased absorption of blockage?
They clear the organophosphate somehow with the heme absorption. So it's like dialysis.
Okay.
And then there's a membrane that they use, which has the
So you mean you
Think that-
ultrafiltrate the
yeah.
so you
They call it they say it's not ultrafiltration, but the heme absorption. So
you mean as a mode of treatment, actually.
Yes, as a mode of treatment. So most of the patients now that land up, in fact, all the patients that land up in para ICU get into the study. So might get into the study.
Michael,
Get recruited in the study.
you just came from there a few days ago. Any idea how did you manage ICU patient, Darren? Any comment on that?
We see a lot of this. So I don't know if you know, but Tembisa's casualty system has kind of malfunctioned a little bit after the fire. So a lot of those medical emergencies come to us. And since then, I don't think there's been a week that we haven't had at least one organophosphate in the ICU. So our mortality matches what you show there. I think what you don't show is how much morbidity there is and the length of stay that these patients have in the ICU. They can spend weeks in the ICU because they very often come with mucus plugs, aspiration pneumonias, all sorts of issues, chronic weakness after the exposure, which makes it difficult to get them off the vent. So it's not just the acute toxicity that we battle, but it's all the downstream effects. So there's always someone in the unit. Overall mortality is around the same. That two-step, we get a lot of patients that tell us they're taking two-step, but as far as I know, it's from that you take 2 steps and then you fall over.
that takes two
Yeah.
steps.
That's where the name comes from. So an ex-colleague of mine, a friend who works at Barra Emergency, they actually now have formulated a large vial of atropine. I think it's a 500 milligram vial, because you can imagine if you're making infusions, how many vials you have to open. You can fill a whole shops container for patients. So they're now developing these 500 milligram vials so they can run these infusions because of the demand. So in the state sector, I think it's the cost of the poison still a massive issue.
But not to mention also the delayed diagnosis, because not many people have access to the pseudocoronary risk labels. And sometimes you find out because while you do the test, I remember that you wait for like 48 hours or so. Yeah, and that's where I mean, private we have access to we can get within 4 hours, I think, in midstream. But obviously, when in government sector, if you're not in central like it's the big in Kalafong, it's actually take a while, like if you're in periphery. And we see that quite a lot, like when you go to Jane First and Rita's Hospital, you see quite a lot of things actually. Some of those patients are actually and dying.
Can I ask a practical question? If a person has low levels but no symptoms, are they safe to be discharged, or do you have to keep them until levels normalize?
You can see that in this case study, they tracked it until it looked like it was recovering, and then they left it. So the chances of relapse is small. There will not be any more exposure risk, contamination of that from next week. The trend is there. It's very unlikely that it will.
So we had actually a patient that was, I think, 6 months ago, was from midstream actually who did that. He was going through a difficult time, and I remember that the pseudocholesterol level drops and give atropine and went to 5,000. And he was in the ward when we were about to discharge. We repeated it when he went home, and the fund actually dropped to less than 2,000. So I have to call him back again for the treatment. So the question is that
What happened in between?
yes, well, because he was well, so we put him in the ward, observed, getting psychiatric support and everything. And only that's like, by the way, let's just check before he goes home. But then, of course, the result take 2 hours. He just decided to go home because he was in a hurry. And then, of course, in the evening, we have to call him back. And then, like, now the medical guy said, no. Why did you call him back? I said, but that's what's the result. Yeah. So after 2-3 days, I think we have to more atropine, then stabilize quite very nicely. Yeah.
But it doesn't look like we get redoxylene in South Africa.
So what other oximes are there?
So we do get glycoprotein. Is it not?
Yeah.
Glycoprotein. But we use, but I think in private you've got more fancier things. But you had private.
So myocardial is an antimuscarinic. So the equivalent, if it's in that was available, is opidoxine. Yeah, but I don't think it's in circulation anymore. Only available via Section 21. Specific.
So you treat your patients with atropine.
Yeah, so
We do the whole way.
So it's more a symptomatic treatment, if it seems.
But I think we have one of the very interesting case that I don't know whether we should one day present this platform. But it was a young boy who came to us with a link at my head.
Chat.
Anybody, any person online? Dr. Godinho, are you there?
I'm here.
Welcome. Nice to hear your voice.
No, thank you for the presentation.
Thank you. Please join us next week, please. We miss you.
I'll be back.
And Dr. Okoli, any questions? Is it okay?
And then I'm going to stop.
Okay.